Hi guys, welcome to another episode of the Crash Course series of the OMFS DCT Survival Guide. We're going to be looking at episode 2 of Basic Interpretation of Bloods, and today we're going to be focusing on the urea and electrolytes, so U&Es. My name's Shona Garland. I'm one of the second degree medical students, and I'm going to be taking you through the cases today. So as always, we're going to start with our aims and objectives. So you want to know why you're going to be ordering your U&Es, know the cause of both high and low sodium and potassium, understand the pathophysiology behind certain trends in the blood tests, and understand which cases may need further investigation or management by MaxFax or another medical team. So we're going to start off with case 1. You're the on-call DCT or SHO and are called to see Derek, a 34-year-old male who has a right-sided submandibular swelling. His past medical history of anxiety and depression, and he takes sertraline for this. Socially, he doesn't smoke at all, he drinks 20 units of alcohol a week, and he's currently a builder and he lives alone. So you want to start thinking about what potential differential diagnoses we may have here. Submandibular swellings are commonly abscesses. We also want to think about other things in that area which may cause swellings, such as salivary gland pathology, such as a sladenitis. Medically, probably unlikely anything contributing to the patient's presentation, but it's always really important to think about the patient's medical history. Has the patient's medications affected their presentation? So this patient's in A&E and you get given some observations. So the patient's oxygen saturation is 97% on room air. They have a heart rate of 102, a blood pressure of 122/88, and a respiratory rate of 16. Their temperature is 38.1. So you want to know what normal is and look at whether these are abnormal. So the patient's oxygen saturation is normal. The heart rate is slightly high, so this could be due to the infection. It could be leading to sepsis, but it may also be due to pain if the patient is presenting with a painful swelling. The patient's blood pressure is okay and that's stable, as is the respiratory rate. The patient does have a high temperature, and this could also suggest that the patient is septic. So in this patient, what do you want to think about? In the management of the patient, you always want to think about the sepsis 6 in making sure that you manage these patients appropriately. So you go and see the patient and you get a history from them. They tell you they have a 5-day history of the pain and swelling. They have associated odynophagia, which is pain on swelling. They deny any toothache or having any recent dental treatment carried out, and tell you that the pain is made worse by eating and drinking. They also have had a reduced oral intake because of the pain that they get with it. So just going by the history alone, the pain which has been made by eating and drinking is commonly associated with salivary gland pathology. So in this case, you would probably be thinking salivary gland, but you wouldn't rule out an abscess. You want to do a thorough examination and look at your investigations to get the correct diagnosis and ensure you're managing the patient well. So of course you can move on and do your examination. So the patient's airway is patent. There's slight asymmetry on the right hand side extraorally, and there's a firm tender swelling in the left submandibular region, and you have associated firmness in the right floor of mouth. Dentally, the teeth look fine. There's no sign of caries or any tender teeth, no teeth or TTP, and there does appear to be pus draining from the floor of mouth. You get an orthopentanthogram or an OPG, and this confirms that there's no dental involvement. So using your clinical knowledge, the examination confirms that this is likely a sladenitis associated with the right-sided submandibular gland. So we have a little look at the patient's bloods. So starting off at the full blood count, we can see the patient's got a raised white cell count at 13.4 and a raised neutrophils at 9.1. The hemoglobin, the MCV and the platelets are all normal. Looking at this along with the raised CRP, it gives an infective picture which is in keeping with the patient's presentation of a submandibular abscess. looking at the topic of today's talk, the urea and electrolytes. So we'll go into a little bit more detail in a minute about what each one is, what it means, what high and low can potentially mean. But you can see that the patient has a high sodium, 148, potassium is normal, the patient's urea, creatinine are high, and the patient has a low estimated glomerular filtration rate. Now, some information to know about making a diagnosis of what a patient has is you'll be thinking this patient either has an acute kidney injury or chronic kidney disease. You can't make this estimation unless you have a previous blood test. You want to compare and see if the eGFR is the same or is it a drastic change. If it's the same, the patient is likely to have chronic kidney disease. If it's a drastic change, this is more of an acute picture, and the patient would be likely suffering from an acute kidney injury. So we're going to have a little look at what causes a high sodium, potassium and urea, and we'll look at creatinine and eGFR in a minute. So this patient presented with a high sodium, and this was likely as a result of dehydration. And this is because the volume of water in the blood decreases, so the concentration of sodium then goes up. Other causes of high sodium: diabetes insipidus, Conn's syndrome, IV saline. So diabetes insipidus is a problem with a chemical called vasopressin, which is involved in sodium balance, and it causes excess thirst and urination, which is why it's called diabetes. Conn's syndrome is primary aldosteronism, and this is where there's too much aldosterone produced, and this in turn causes a high sodium. In terms of signs and symptoms, you can see with these patients, they can have confusion, muscle twitching, seizures, and can lead to coma as well. So causes of low sodium: syndrome of inappropriate ADH production, diuretic use, and Addison's disease. So syndrome of inappropriate ADH is where the body produces too much ADH, and this causes the body to retain too much water. There are many different causes, one of those being cancer. Addison's disease is an issue with the adrenal glands where they don't produce enough steroid hormones. In terms of signs and symptoms you'd see with these patients, they have nausea and vomiting, headache, confusion, lethargy, muscle weakness, and it can also lead to seizure and coma. So moving on to potassium, so causes of high potassium: renal disease, medications, Addison's disease. Examples of medications would be like ACE inhibitors or ARBs. In terms of symptoms: tiredness, weakness, and it can also lead to cardiac arrhythmias, which is one of the things you really need to take away with this. It can be very dangerous. Causes of low potassium: having poor intake, diarrhea, diuretics, so making you pee it all out, diabetic ketoacidosis, and a low magnesium can impair your ability to keep a high potassium. So in terms of signs and symptoms, they may get muscle weakness, and they may get pain and constipation. So finally, moving on to urea. So urea is a waste product of the breakdown of proteins, which are usually excreted by the kidney. Common causes of high ureas are renal disease, dehydration, and if there's an isolated rise in urea without creatinine rising and eGFR falling, you're going to want to think about an upper GI bleed. This is because the red cells are broken down in the stomach and the urea leaks out and is absorbed into the blood. And then causes of a low urea, you're looking at a low protein diet and malnutrition. So creatinine. Creatinine is a waste product from the muscle after carrying out aerobic respiration. You get high creatinine in renal disease, and if the patient has high muscle mass, because you're obviously going to have more byproducts because they've got higher mass. A low muscle mass and malnutrition, essentially, when they've got muscle wasting, that sort of thing. An eGFR, you don't tend to have any issues with a high eGFR, but low eGFR, you're thinking renal disease, so acute kidney injury or chronic kidney disease. But this is really important with patients who have a lower eGFR. They may need their doses of their drugs adjusting because the kidneys don't clear it well, and they may need extra fluids before a CT scan just to flush the contrast through. So this is all something to bear in mind. So of course, this is probably a bit complicated to deal with by yourself when you're first starting out, so you discuss this with your on-call registrar. So the registrar tells you to find some previous bloods, and you find some from 6 months ago, and the patient's U&Es was normal. So this is an acute picture. And the patient does tell you that they've been drinking very last few days because of the odynophagia. So this makes chronic kidney disease quite unlikely, and it makes it likely that the patient is suffering from an acute kidney injury. And this is probably secondary to the patient drinking very little because of the odynophagia that they've presented with, secondary to their celladinitis. So acute kidney injuries. An acute kidney injury is an acute drop in renal function which is diagnosed by looking at a rise in creatinine, or it can be a drop in urine output. It's classically put into 3 different causes. You have pre-renal, renal, and post-renal causes. Common pre-renal causes are things like dehydration. You're reducing the preload to the kidney. Common renal causes are things like medication related or other things like glomerulonephritis. And post-renal causes tend to be obstructions, so things like kidney stones or strictures in the ureters or the urethra, so a narrowing which is obstructing flow of the system. So what would be the management of this patient? You want to start them on IV antibiotics, an appropriate antibiotic as per your trust guidelines, and you want to start them on fluids. You want to fluid resuscitate this patient. They have a kidney injury. You want to get some fluids in them and try and improve their renal function. So you get some bloods a couple days later. Let's look at the full blood count to begin with. So the white cells have dropped down to 11.1 and the neutrophils have dropped down to 7.6. The rest of the full blood count is normal, and that's an improvement. The inflammatory markers seem to be trending down, which suggests that the infection is clearing. Looking at the U&Es, they're all normal now. The acute kidney injury seems to have responded to the fluids that the patient's got, so that's all positive. So to conclude the case, the patient recovers well and is discharged from care. Patients like this, you may want to follow up what's caused the celladinitis in a relatively young, fit, healthy person. They may have a stone in their gland. It may require removal at a later date, but you want the infection to be cleared first. So moving on to case number 2. So you're the on-call SHO or DCT. Fred is a 76-year-old male who was admitted 3 weeks ago for an excision of his SCC of the right floor of mouth and had this reconstructed. He had a rig placed 3 days ago. Medically, he suffers from ischemic heart disease, hypertension, COPD, and depression. Socially, he is a previous smoker and has 40 pack years, drinks 20 units of alcohol a week, and is a retired plumber. So you want to think about what could potentially go wrong in a patient like this. They have a lot going on medically, lots of medications, and medications have side effects, so this is something to keep in mind. So we're moving straight on to some investigations for this patient. As you should do for normal patient care, you review their bloods. 3 days ago, the bloods were normal. Today, you notice the patient has an abnormality. The CRP has been stable, the full blood count is normal 3 days ago and is still normal. The U&Es, you spot an abnormality. The sodium has dropped from 139 to 128, so the patient has developed what we call hyponatremia, which is a low sodium. And this can often be due to water excess, so giving them too much fluids, or sodium depletion where they don't have enough salt in their blood. So hyponatremia. Hyponatremia being a low sodium in the blood It can be caused by fluid overload, certain medications such as omeprazole, diuretics, endocrine issues. So the sodium level in the blood can be low because of an increase of water in the blood volume, and it causes a dilational effect. It can happen with fluid overload, and it can also happen with a syndrome called a syndrome of inappropriate ADH secretion. This is when the kidneys absorb too much water, and it can happen for a number of different reasons. In diabetic patients, you can get a disease called hyperosmolar hyperglycemic state, and this is where they have too much water moving into the extracellular area because of a raised glucose. If it's untreated, it can cause cerebral edema, and that can lead to herniation of the brain, which is obviously a devastating complication. Management can be quite complicated, and if it's severe, patients may need monitoring in the high dependency unit. You really need to be careful about correcting it too quickly, because it can lead to something called cerebral pontine myelinolysis, which is essentially stripping the myelin off the pons in the brain, which can cause locked-in syndrome. So correcting your sodium too quickly can be devastating. So this is normally led by medics. So this abnormality has been noted on the patient's blood. So you review the patient on the ward who appears to be asymptomatic. So you then also discuss the results with the registrar. They ask you to review the patient's fluid balance and their drug chart, and also order a urinary sodium test, which is done by a urine sample, because this aids the medical team in seeing what the potential cause of the sodium disturbance is. In diabetic patients, a capillary blood glucose should always be taken to rule out the hyperosmolar state, because these patients can become very unwell and they can happen very quickly. So you carry out a medication review. You look at the patient's regular medications: simvastatin 80 mg once daily, sertraline 50 mg once daily, paracetamol 1 gram 4 times a day, lansoprazole 30 mg once daily, senna 7.5 mg once daily, incruzilipta twice daily, bisoprolol 10 mg once daily, amlodipine 5 mg once daily, and as required, GTN spray, Oromorph, and salbutamol. So in terms of what these medications are for, simvastatin is for correcting your cholesterol, sertraline is for the anxiety and depression, paracetamol is an analgesia, lansoprazole is a PPI and can be used for GORD. In this case, it will likely be post-RIG placement. Senna is a laxative, incruzilipta is for the COPD, is an inhaler. Bisoprolol is a beta blocker used for heart failure. Amlodipine is a calcium channel blocker, which is also used in the ischemic heart disease. As required, GTN spray for the ischemic heart disease, Oromorph for pain control, and salbutamol for the COPD. So looking at the side effects of these medications, senna can cause electrolyte imbalances. Prolonged use can cause hypokalemia, so low potassium. So that's unlikely to be a cause of anything. Salbutamol can also cause hypokalemia in high doses. However, this patient is unlikely to be using it in high doses, and it also is affecting the potassium, not the sodium, which we're looking at. And rarely, PPIs, so lansoprazole in particular, can cause hyponatremia. This patient will have been started on the PPI after having their RIG carried out. So this could be a potential cause of their hyponatremia. So you examine the patient, you want to see what their fluid status is. The patient's chest is clear, the capillary refill time is less than 2 seconds, he has moist mucous membrane, there's no signs of any peripheral edema, and there's normal skin turgor. The patient appears to be euvolemic, which essentially means they're neither fluid overloaded or dehydrated. So this all seems to be normal. So the conclusion of case 2, you discuss the case with the medical registrar, They then review the patient and decide to fluid restrict the patient into contact if there's any further issues. Now the causes can be multifactorial, and it's really important to consider different causes. Okay. And moving on to the last and final case, case number 3. So you are the on-call DCT or SHO and are called to see Mohammed, a 41-year-old male who has a 3-day history of a left-sided submandibular swelling. Medically, he suffers from asthma and has type 1 diabetes mellitus. Drug-wise, he takes regular, as required, salbutamol, clinomodulate, and he has his insulin. He has an allergy to penicillin. He smokes 10 cigarettes a day and has done for the last 15 years. Doesn't drink any alcohol and is currently unemployed. So again, you want to be thinking about what are you going to be looking for in this patient, what do you want to have to look at, do you want to see some observations, what investigations do you want to get for this patient, how is the medical history going to affect the patient, is it significant? So before actually assessing the patient, you look at the patient's observations. So he has an oxygen saturation of 97% on room air, a respiratory rate of 17, a heart rate of 88, a blood pressure of 132/88, and a temperature of 37.2. All these observations are normal within normal ranges and wouldn't concern you. This patient appears to be systemically well, and there is no currently signs of any sepsis, which is something you always want to consider in patients who have abscesses. Always think of sepsis. So you go on to examine the patient. There's no sign of any airway compromise. The airway is patent, the patient's speaking and talking back to you. There is a left-sided asymmetry on there's asymmetry on the left side extraorally. You can see the swelling when you look at the patient. The patient has a mouth opening of 2.5 millimeters, and there is a carious lower left 7 that you can see clinically. The floor of mouth is soft and the tongue's freely moving, which is really important to assess swellings. And there is a firm left-sided submandibular swelling, and the patient doesn't have any dysphagia or dynophagia, which is difficulty swallowing and pain on swallowing. So taking the observations into consideration and the examination findings into consideration, the patient has a swelling, however, he is not septic and you're not worried about his airway, which are a couple of things to really find out early on and know what the answers to these questions are. So we get some investigations for the patient. You get some blood tests. So you have a little look at them. You look at the full blood count. The white cells are 14.4 and the neutrophils are 12.6. These are high, and it would be in keeping with an infection as well as a CRP of 215. So this patient has an infection. The patient's urea and electrolytes are normal, so there's no concern there. So of course you're going to admit this patient and give them some IV antibiotics. Now something to remember with this patient is they had an allergy to penicillin. So you're not going to be putting this patient on a penicillin, you're going to be putting them on an alternative antibiotic, and this will be guided by your trust guidelines. So as I stated in the last slide, the patient's admitted for IV antibiotics and for surgery. They'll be nil by mouth the next day or for their surgery, and they'll go to theatre and have their incision and drainage of their abscess. As I said, alternative antibiotic from penicillin. So the case continues. You're asked to review the patient the next day by the nursing staff. The patient has developed severe diarrhea, and they've already sent off a stool sample for microscopy and culture. So you want to be thinking about what could potentially be causing the diarrhea in this patient. Common causes, especially in hospital, would be things like norovirus that can spread quite quickly. Is it medication induced? You need to have a look at what the medications the patients are on. This patient will likely have been started on clindamycin, which can cause antibiotic-associated colitis, and it is a risk factor for developing C. difficile, Clostridium difficile. So it's something to bear in mind when prescribing patients these antibiotics and knowing what happens if they develop these symptoms. So the clindamycin is identified as likely the cause of the diarrhea and is therefore stopped. So Clostridium difficile is a type of antibiotic-associated diarrhea, and it's caused by the use of broad-spectrum antibiotics such as clindamycin. Treatment involves stopping the antibiotics and treatment with alternative antibiotics, and the infection can be spread by spores found in feces. The reason it happens is the antibiotics can change the gut biome, so it's important to treat it because it can cause really serious complications such as the development of pseudomembranous colitis, something called toxic megacolon, which can lead to bowel perforation and therefore sepsis. So these patients tend to be moved to a side room to prevent the spread of infection, and with these patients it's really important to wash your hands, not alcohol gel, because that prevents the spread of the infection. Alcohol gel is not sufficient with Clostridium difficile. You need to wash your hands. So we move on to the management of the patient. In cases like this, it's really important to discuss it with microbiology. They're going to advise you what antibiotics to change the patient to and what antibiotics to treat the Clostridium difficile. So you discuss them with microbiology, and they advise alternative antibiotics for the dental abscess and antibiotics to treat the C. diff. So we get some more bloods in the patient. You can see the bloods from admission and the bloods from today. So the inflammatory markers from the full blood count appear to be trending in the right way. They're trending downwards, which means the infection is likely resolving, obviously from the antibiotics and from the operation they've had done. Now, those inflammatory markers will have been raised because of the infection, and will also be raised because of the colitis that the patient suffered with. When we look at the patient's urea and electrolytes, the urea is high, the creatinine is high, and there's been a drop in the patient's eGFR, which does suggest, previously we've discussed, a deterioration in the patient's renal function. The patient has also had a drop in the potassium down to 2.9, and this may be a result of excessive diarrhea from the C. difficile and excessive fluid loss. So this needs to be replaced with oral potassium, which is known as Sandoke tablets. And it should be prescribed for a couple of days and the blood's rechecked to ensure the levels are resolving. If the potassium continues to drop, the patient will need an ECG to a tracing of their heart and replacement IV. You need to look at your trust guidelines. The management for electrolyte disturbances is always found in a handy flowchart. High potassium can be more of a concern. This can occur when a patient has an acute kidney injury, when they have CKD, because the kidneys can't get rid of the potassium. Some drugs also increase your risk, such as an ACE inhibitor, like ramipril or lisinopril, angiotensin receptor blockers, such as losartan and NSAIDs, basically medications which can induce an acute kidney injury. If you notice the patient has a high potassium and it's above 5.5, the most important thing to do is an ECG, and you need to get a doctor to check it and review the patient, because a high potassium can cause dangerous arrhythmias and it can lead to a cardiac arrest. If it needs treatment, the medical team will advise on the treatment, and you can also consult your trust guidelines. Thank you guys so much for listening to the talk. We've got some further reading here. As always, you've got On Call and Oral Maxillofacial Surgery. It's a great book and it talks you through all the assessments that you need to know. The BNF is also super helpful whenever you're looking at medications, medication side effects, things like that. OscuStop's got a great section on bloods interpretation, and Geeky Medics and Mindably are great information sources for things like acute kidney injuries and things like that. So thanks so much for joining. If you do have any questions, please do email the address at the bottom. And if you want any more information, or want to see any other videos, please look at the website omfssurvivalguide.co.uk, and thanks again.